Tonight I'm going to be recording Ryan as he checked off on chest and lungs. It's Saturday, October 29th at 12:28 and a 15-minute start now.
Okay. Hey. Okay, well first I would enter the room, wash my hands first, then approach the patient. Hi, my name is Ryan Bacai. I'm a student at Liberty Nursing, and may I have you state your name and date of birth?
Tim Fink, 4492.
Okay, that's great. Well, I'm here to assess your chest and lungs today. I'm just going to go ahead and ask you to remove your shirt. Thank you so much. Okay. Well, I'm here to first I'm going to go ahead and just identify the anatomical landmarks. The clavicles, suprasternal notch, the manubrium, circle of Levi, sternum proper, and the costal angle. Next, by inspection, I've noticed that there are scattered maculas across the chest, and no papules. It just seems to be a little bit of redness, but that's fine. Probably a little bit of irritation. Next, patient is a diaphragmatic breather. He's breathing with his belly, and he's absent of costal breathing, not breathing with his chest. Patient is absent of respiratory distress, excessive use of accessory muscles, retractions, and nasal flaring. Next, breathing description. Patient is non-labored, symmetric, regular breathing, covered in vitals, and regular, rhythmic, covered in 12 to 20 minute. AP diameter seems to be less than transverse diameter. If it were to be equal, this would suggest barrel chest. Absent of stridor, cyanosis, clubbing, again covered in vitals. Patient is not indicative of pectus carinatum. The patient would show signs of protrusion of the chest, pigeon chest, or pectus excavatum, which would be a retraction of the sternum. Next, just by looking at the patient's posture, he's in normal posture, absent of kyphosis, which would be cervical deviation of the spine, scoliosis, deviation laterally of the spine, and lordosis, deviation of the lower lumbar. Next, just to palpate for tenderness, lumps, bumps, I would assess the patient's thoracic cavity. You find any tenderness in the areas under the chest, the sides, and the clavicles. Okay, bilaterally assessed. And thoracic expansion. Okay, next I'll be assessing the patient for thoracic expansion. I'll find the 10th intercostal space and have the patient breathe. Breathe. Breathe again. Okay. Patient is symmetric breather. No abnormalities. Assessing the patient for the posterior thorax, I would percuss along the scapular line. Have the patient lean forward, cross his arms. This will separate the scapula, move him aside. Moving side to side, comparing right side to left side, and moving down. Okay. I found that it's all over this lung field. It's resonant all the way around, but the right side seems to be more resonant than the left side, since due to the liver pushing up against the right lobes of the lung field. Next, assessing the patient for diaphragmatic excursion, I would have the patient completely inhale first, and I will measure the difference from the change from resonance to dullness. Okay. Alright, so inhale now. I'm backtracking just to make sure the change. Okay. Breathe out. We're going to do this again. This time we're going to move from the base of the scapula upwards, whereas last time we moved from the top to the bottom. Alright, completely exhale now. Okay. Change from dullness to resonance was noted at this point. Next, I would take my tape measure and measure it. Okay. 1, 2, 3, 4. Okay. You can relax now. Okay. According to my findings, that the patients have diaphragmatic excursion of the left lobes is 4 centimeters, commonly found 3 to 5 centimeters. These patients in normal finding range. If it was lower than 3, this would be indicative of pneumothorax or emphysema. If it was above 5, this is a common finding in athletes, and this is bilaterally assessed, of course. Next, I would perform auscultation tests on the patient. I'll have the patient still supine from before and cross his arms. And I'm going to go ahead and auscultate 10 to 12 spots along the backfield. Alright, and he will breathe even, slow, deep breaths every time. Go ahead. Okay, that side was assessed. I didn't find any abnormal sounds. Covered later. Next, I'm going to have the patient. I'm going to perform an auscultation test in the frontal view. The apex of the clavicles, second intercostal space, fourth intercostal space, and the midclavicular line. So I'm going to go ahead and start. Breathe for me. Sleep. Deep, even sounds. Okay. Next, I'm going to be performing an auscultation test on the lateral view of the patient. The patient crosses arms, still supine, starting at the axillary cavity right over here. Do that one again. Okay. And the last one. Okay. Auscultation test is now over. You can relax now. I found that the patient's absent of adventitious sounds, crackles, coughs, pleural rubs, and such friction rubs. Also, I overheard high-pitched, high-intensity sounds over the trachea, which would be bronchial sounds. Bronchovesicular sounds were heard over the major lobes of the bronchi, moderately pitched, moderately intense. Vesicular sounds, low-pitched, low intensity overheard in the lower, in the minor lobes of the bronchi. And if adventitious sounds were overheard by the patient, which is absent in this one, we would perform vocal consolidation tests such as the bronchophony, have the patient say 99, egophony, have the patient say E, and note if there was a change in the note of E to A, and I'll whisper pectoriliquy test and have the patient whisper to me. And that should be it. Trying to think. And that concludes the assessment for chest and lungs.